Good morning, brothers and sisters. It's been quite a while since we updated you on bargaining, and today we're going to try to bring you up to date and for where we are from last week at our mediation on August the 2nd and 3rd. Brother Don Griffin is going to go through a little bit of the history and both proposals, ours and the carriers, and kind of where we are, and just to at least let you know, after mediation last week, I'm a little encouraged that we may have a platform to bargain again, and things may move. Having said that, they may not as well, but we'll do our best to keep you up to date, and stay tuned and listen carefully.
Thanks, President Simpson. Good morning. It's early morning on August the 8th. I want to give you a brief update on what happened in mediation last week. But before I do that, I want to begin with sort of a review of the mediation process, the bargaining process, and how we got where we are here today. We haven't done an update in a couple of months. That's because we haven't had a meeting with the carriers in a couple of months. So we're in mediation now, and so what does that mean? So that means that our bargaining now is under the control of the National Mediation Board. Mediation Board is an agency created under the 1934 amendments to the Railway Labor Act. When the Mediation Board takes jurisdiction of bargaining, they set the dates for meetings and they control the pace of bargaining. Now, it's important for everybody to understand the role of the NMB is to try to get the parties to make a voluntary agreement. The NMB does not take sides in the bargaining process. They simply are there to mediate, to try to get the parties to reach a voluntary agreement. The June session, for example, was canceled specifically at the direction of the Mediation Board because the available mediators could not meet on that date. Now, in the mediation process, the Mediation Board is given great discretion to continue the bargaining process until it deems the parties cannot agree on a voluntary deal. That then leads to what's called a Proffer of Arbitration. Now, under the Railway Labor Act, arbitration is voluntary to settle the terms of an agreement. If the parties don't agree to arbitrate their dispute, that begins a 30-day cooling off period that can lead either to a strike or to the creation of a presidential emergency board. It's important for everybody to understand there is no timeline on mediation. It is completely open-ended. And you go, that can't be possible. Well, it is possible, and I'll give you a couple of examples why that is so. I'm aware of at least 3 occasions where unions have gone to court to suing the Mediation Board saying, we need to be released from mediation. There is no way we're making a voluntary deal with the carrier. In all 3 cases, either the district court or a reviewing appellate court has said, no, the Mediation Board has virtually unlimited discretion to determine when mediation should end. If you wonder how long mediation can last, well, from personal experience, I can tell you at least 8 years, because that's how long the unions were in mediation with Amtrak about 10 years ago. So we're in a process. It will either end with a proffer of arbitration or a voluntary deal. When that will occur is both up to the parties and up to the Mediation Board. With that as a background, I'd like to go into a brief discussion of what occurred on August 2nd and 3rd. The August 2nd session was attended by an actual member of the National Mediation Board, Linda Pashala. She has been on the Mediation Board since 2009. And prior to that was a longtime federal mediator working at the National Mediation Board. At the end of the 2 days that we spent with the mediators, it was clear that the board member and the assigned mediator fully understood our proposals. And when I say they understood our proposals, they not only understood the dollars and cents of the proposals and the mechanics of how our health and welfare proposals would work, but they also understood the why of the proposals we put on the table. And their understanding of the why, in my opinion, is essential to any hope that the Mediation Board can help us get to a voluntary deal. Remember, as I said at the beginning, The mediation board's job is to understand the parties' positions and proposals and then try to use that information to figure out a way to get the parties to make an agreement rather than to continue to sit at the table and disagree. It's a long, messy process, but that's what the mediation board's job is. Try to get the parties to reach a voluntary deal. Now let me move on to the details of the actual proposals that were put on the table. There really wasn't a great deal that was new in those proposals, and I'll start with the NCCC's proposal, which was given to us on August 2nd. First off, it's very similar to the proposal they gave to the Coordinated Bargaining Group in June of this year. The NCCC proposal of August 2nd, I've been informed, is now on the BMWED website, so if you want to look at the specifics of it, you can go there. I want to highlight the points of that proposal just so people understand where the carriers are coming from. First off, their proposal continues their position of no retro pay. So in other words, what they have proposed is the first wage increase will be 4% on the effective date of the agreement, followed by an additional 2% increase in 2018 and another 2% in 2019. Their wage offer was reduced, in their opinion, to sync up with alleged losses that they haven't achieved in health and welfare changes. Now, our economic expert looked at their syncing up, not that we think it's appropriate in any circumstances, but said that they essentially made up those numbers, and what they've done, in essence, is take an additional $50 million off the table in wage increases for BMWED and Smart Mechanical members. In addition, they still have proposals to contract out crossing renewal and building maintenance work, and their incidental work simple task rule is still on the table as well. Their proposal, comparing their February 28th proposal to their August 3rd, their February 28th proposal, as it would apply to an individual, the average BMWED Smart Mechanical member, would, over the term of the agreement, provide annual wage increases of 1.4% and result in about $11,000 in additional money earned over the term of that 5-year deal. The August 2nd proposal is actually worse. It drops to a net annual increase of 1.2% and a little over $10,000 in actual increased earnings over that 5-year period. Now, we presented a counterproposal on August 3rd. It is in many ways identical to the proposal that we made on February 7th. Again, that proposal is also available at the BMWED website. What was changed in our proposal is a withdrawal of all proposed increases in deductibles, out-of-pocket maximums, and doctor and pharmaceutical co-pays, except for the following. We retained an increase in the emergency room co-pay. It's currently $75. We proposed on February 7th $100, and we left it at that. Now remember, that is a co-pay that only applies if you go to the emergency room and you are not admitted to the hospital. We have also proposed to add what are called teledoc and telemental services. Teledoc is something where you can call a doctor on the phone, you can engage in a FaceTime or some other form of video chat with the doctor, and the doctor's able, as a result of that phone call or video chat, to prescribe medications for you. We proposed a $5 copay for the teledoc service. Telemental is, again, a phone, FaceTime, video conference call with a mental health professional. We proposed a $15 copay for that. We did not value that as a savings or a cost to the plan. Our experts believe that over time, the teledoc and telemental services actually will provide some savings to the plan. They certainly provide convenience to the members because they are an additional way somebody can interface with a doctor or a mental health professional. In addition, we added something that's called Smart 90. And Smart 90 simply is something that I believe it's operated through Walgreens, and it allows somebody to get a 90-day prescription filled at a brick and mortar store at the 90-day prescription prices. Again, we think that's an advantage to the members. It provides, probably it's a cost neutral to the plan. We have also proposed adding something that a company called Vitals runs, which is called Smart Shopper. And the way Smart Shopper works, in essence, is that say you go to the doctor and the doctor says you should get an MRI on your knee. The member then calls Smart Shopper, says I've been prescribed an MRI on my knee. Smart Shopper will then refer the member to somebody who is in network that is the lowest cost provider. If you go to that lowest cost provider, what happens is Smart Shopper takes some of those savings and the member actually gets some of those savings rebated back directly to them. It saves the plan money, it saves the member money, the member gets some money back in pocket. Other than that, we propose no changes to the cost sharing amounts. They would remain as they are today at $228.89. Now, our proposal, when you compare it to the carrier's proposal, first looking at the February 7th proposal, that provided a net wage increase of 3.2% each year over the term of the agreement and would provide the average member about $29,000 in additional compensation over the term. Our August 3rd proposal actually increases the net wage increase to 3.5% over the term of the agreement each year. And that comes from both the increases in medical benefits that we've proposed, the increases in dental, life and AD&D, and vision, but also the fact, and I'll talk about this just in a minute, our health and welfare proposal would actually put more members in managed care, and that would result in additional savings to the members by being in managed care rather than in the comprehensive health care benefit. So our August 3rd proposal would provide over term almost $31,000 to the average BMWED or smart mechanical member. So that's a brief discussion and review of the two proposals that were tabled in the last bargaining session. Now I want to talk in a little bit more detail about the health and welfare issues in this round, what the carrier's view of it is, where they're trying to go, and specifically talk about our plan, which is we now call the 357 plan, and explain why we proposed it, its mechanics, and what we think it could save the plan, making absolutely no changes to benefits whatsoever. Now, what the carriers are seeking here in changes in the plan to reduce the benefit ratio to 85%. Now, what does that change mean? It means what the carriers want is for insurance to cover 85% of the medical costs incurred by a member or a member of their family. The employee then is supposed to pay 15% of those costs. Now, it's important to remember when we're talking about those percentages of costs, the $228.89 that every member pays in cost sharing each month is not part of that equation. So this is 15% of your medical costs over and above the cost sharing amount. Presently, the plan pays somewhere between 91 to 93% of medical costs, excluding the cost sharing amount. Needless to say, the carrier's ask on this issue is huge in cost shifting to employees. For example, to give you an idea of where the carriers want to go, they have increased their proposal for deductibles to go to $1,400 for a family over the course of a single calendar year, and the out-of-pocket maximums up to $6,000 over the course of a calendar year. It's a huge cost shifting to the members and their families. So what has been the BMWED and Smart Mechanical response to this? We began early on, and I'm talking about prior to when bargaining began, to look at the National Health and Welfare Plan and figure out, are there ways we can achieve savings in the delivery of health care to the members without making benefit changes? Our goal was to try to stop the trend of passing increased medical costs in part on to the members. So our solution is what the mediators called the 357 plan and what the parties now refer to as the 357 plan. So I'm going to describe that plan in some detail. It will also explain where that number 357 comes from. So going back sort of to the beginning and the establishment of our current National Health and Welfare Plan, it comes out of PEB 219 back in 1991. So over 20 years ago, as the parties were beginning to implement this new plan and set up managed care networks, the U.S. was divided up essentially between United Healthcare and Aetna regarding network providers. Blue Cross Blue Shield wasn't in the mix at that time. Now, the map that was drawn up about over 20 years ago, actually, really has never been redrawn since. And I'll give you an example. If you look at the current map and distribution of networks, the state of California is almost exclusively a United Healthcare area. At that time, the map was based on which provider, United Healthcare or Aetna, had the best discounts and the best physician availability within those networks. The area chosen at that time could have been a whole state, like California, could have been part of a state, or it could have been simply a metropolitan area. The map, as I said, was a product of the establishing of managed care following the PEB 219 recommendations to change our health care plan to a self-insured plan that included managed care networks. Look, what might have made sense 20 years ago may not make sense today. I mean, things change over time, right? So that's the motivation behind the 357 plan, and it's based on several years of study and analysis of the provider discounts and actual claim experience under GA 23000, the National Health and Welfare Plan. So what the 357 plan does is it redraws the map based on 357 standard metropolitan statistical areas. And each of the three current vendors that we have, United Healthcare, Aetna, and Blue Cross and Blue Shield, are involved in this analysis. So we look at the actual claim experience under the plan and then apply the best network best network discount currently offered by either United Healthcare, Aetna, or Blue Cross Blue Shield in each of the 357 standard metropolitan statistical areas. When that analysis is done, we then assign the best discount provider to that standard metropolitan statistical areas. If you apply the 357 plan to the current National Health and Welfare Plan, making no changes to co-payments, deductibles, or co-insurance, applying the 357 plan would save the plan $139 million in the calendar year 2018. That number would increase to $149 million savings in 2019 and $160 million in the calendar year 2020. That's all based on a current estimate that there will be about 92,000 employees in the National Health and Welfare Plan, and then add in additionally their dependents, their family members, those in the industry they refer to that as belly buttons. The National Health and Welfare Plan has currently a little over 300,000 people covered under its terms. Now, to give you an idea, $139 million sounds like a lot of money, and it is. It's greater savings than what the carriers received in the last round of bargaining that came out of PEB 243. This is a huge, substantial savings to the plan that asks nothing more from the members in terms of co-payments, deductibles, and co-insurance. We have that on the table. That is part and parcel of our health and welfare proposal, and we believe it is a good way, a good starting point to figure out a way to reach a voluntary deal in this round. Now, what I'd like to do before I finish is we've had some questions from the members come up about the 357 plan and what it means. There's some confusion and misinformation about it, and I'll try to hopefully clarify some of that as I go through these questions. The first question that comes up, and it's one that obviously is on everybody's mind. Okay, let's say the 357 plan goes into place. Wouldn't I have to change my doctor? And the answer to that question is no, it's highly unlikely. I'm not going to say everyone would keep their own doctor. Some people may have to change, but our experts have looked at this. There's a term of art used for this. It's called disruption. And their view is disruption would be extremely low. The percentage of people that would be affected is somewhere well under 5%. And why is that? Well, think about this. If you step back, most of the doctors today currently participate in all of the networks that the three providers have. If somebody's in a United Healthcare network, they're likely to be in an Aetna network and a Blue Cross Blue Shield network now. So in essence, if you go from a UHC network to an Aetna network, all you would get is a different insurance card. Your primary care physician would remain the same. And that all makes sense if you think about it, because if we're applying the provider that offers the best discount in a particular area, well, that probably means that that network provider has a large pool of doctors and is able to drive the best discounts. It offers the greatest group of patients available to doctors, and doctors are going to participate in that network because there are more potential patients available to them. So our proposal, well, you can't ever guarantee that you won't have to change your physician. The 357 plan is not based on this idea that everybody has to change their primary care physician. There will probably be very little disruption. And in fact, I'd like to step back and say, but under the current system, people will say, I know my doctor. And that wouldn't change. That doesn't change. And the answer to that is, well, yes, it does. Your current doctor is simply somebody who has a contract with one of the network providers, be it United Healthcare, Aetna, or Blue Cross or Blue Shield. Those contracts are for a period of time. Usually it's about 3 years. And our network providers negotiate with physicians, groups of physicians, and hospitals. And doctors and hospitals go in and out of network all the time. There is a constant churn of those doctors and hospitals under the current system. Every month, United Healthcare, the plan administrator, sends out a notice to all of the unions identifying those physicians, physician groups, and hospitals that are on a 90-day countdown to an expiration of their contract, letting people know that at some point in the future, unless a new agreement is reached, those hospitals or doctors will go out of network. So there always is this churn of doctors and hospitals going in and out of the current setup. The 357 plan certainly would cause no more disruption, in our view, than what the current system provides, where doctors and hospitals come and go. Now, another question, very important question, would come up from folks, and that's what if when this switch happens and my hospital isn't in that new network, or my doctor isn't in that new network, and I'm currently under their care? Well, all the states around the country have continuity of care rules. And I could assure you that in bargaining this change, we would ensure that the best continuity of care rules would be applied. So in other words, if you're in the hospital when the switch occurs, or if you're under treatment from a physician when the switch occurs, you would continue until that treatment is completed, and you would continue to be treated as though you were going to a network provider. So people, when this plan was put in place, wouldn't suddenly be cut off and be sitting in an out-of-network hospital and suddenly responsible for much increased charges. That's just not how this would work. So the final question that people ask is, okay, how would this switch take place? Well, I'll try to go through the way we believe it would be implemented and the way changes have been implemented in the past. For example, in 2007, when Blue Cross Blue Shield was added in as another provider in the National Health and Welfare Plan. So how would this switch be carried out? In the first place, we would send out mailings to the members at least 2 months prior to the switch. We would establish a dedicated phone line where people could call in and get answers on the spot. There, in addition, would be on-site meetings with the network providers, and we'd also make sure that webcasts, similar to this, were put up online so people could go watch those webcasts, hopefully get a great deal of their questions answered. The new ID cards would be sent out and received by the members about 2 weeks before the switch. And in most cases, as I said, all that would happen is you would get a new network provider card, your doctors would remain the same, and things would proceed pretty much as they are today. That, I hope, answers most of the questions that people would have about how the 357 plan would work. And President Simpson, that concludes my update on the bargaining.
Brothers and sisters, thank you for joining us today, and thank you for assisting in your union and taking interest in the bargaining, all the things that the union stands for, and I encourage you to continue that. And on behalf of the National Division officers, we all want to thank the members for the work they've been doing for the last 2 or 3 months. The organizing group that's been staying on top of the issues and informing our members and other rail workers about the struggles at the bargaining table. If you stay with us and keep everyone in the loop, talk to other craft folks, and encourage commentary and discussion and just debate on our health care plan or anyone else's plans that might be better. We certainly encourage that, but we certainly want you to stay engaged and stay with us. Again, thanks for being with us, and we'll update you following the next bargaining session.
Their proposal was unacceptable, that we believe that it was presented in bad faith.
How do you feel about all that?
Yeah, it's better money. I think we could get more.
No justice! No peace! No justice! No peace! No justice! No peace! No justice!